Your conference is being recorded.
This is Mike. Anybody on the line here?
This is Mark.
Hey, Mark. Good morning.
Hey. Morning.
This is Leslie.
Hey, Leslie. Enjoy the conference down in Memphis?
Yes, I was.
Wish I could have stayed for the whole thing. You guys get... Hey, Mark and Leslie, is anybody else on the line? Hey, we're still getting our technical difficulties worked out. Okay, well, let's go ahead and get started here. Appreciate everybody coming this morning and joining us on the phone. I guess first thing to do is hallelujah. And we're getting started here at 9:10. You guys have a chance to look over the minutes from back on November the 30th?
Yep.
Yes. Okay. Any additions or corrections? Okay. I have a motion to approve the...
I'll move to accept.
Okay, thank you.
I'll second.
Okay. I'll kind of second. Okay. So let's vote. Everybody in favor, say aye.
Aye.
No? Okay, good. All right. From Diffenderfer, we left the R off on the thing here, is a LADAC that's been working for years in Dixonville. He's also a Birchwood Support Group facilitator. And Tom has seen several of our folks over the years for relapse coaching and for level 1 care. And last year at the Birchwood annual meeting, I was able to attend, and we had a big discussion, and we talked about medication-assisted treatment a little bit. And I know this committee has talked about it before, and our stance right now is you can come to TNPAP and be on Suboxone, but we're not going to approve you to practice until you take it off. And as more and more research is coming out with some hard studies saying that people can actually practice on Suboxone safely. There's still, I guess people saying, it's not safe. There's still folks who say that it's not true recovery. I've gone on a lot of websites and actually seen some people who were on Suboxone for years in chat rooms talk about how even though it may have saved their life, they never really felt totally connected to the real world. It was just always something kind of there. They couldn't really put it into words. When they finally did taper off and get off, hear that. But at the the same time, a lot of studies are coming out saying that your typical 12-step treatment centers are so resistant, and they'll even throw reasons in because it would cost them money. I mean, and there may be a little truth to that, who knows. But there's still a lot of folks against it. And so we kind of have research saying, you know, it's unethical to withhold this treatment. Other people saying, well, it's not true recovery. Okay. And then it can be abused in some ways. Some folks continue to use, and if they can't get what they want on the streets, they'll take the Suboxone from going in withdrawal. Some people move by it and sell it. And so there are abuses, but then again, you can come back and say, well, there's abuses in everything in life, you know. So bottom line is, if this is going to help somebody beat this brain-based disorder, should we let them use it? And the equivalents like diabetes, you withhold insulin, I'm not sure if that's totally accurate comparison, but, you know, I can hear it. Same thing, maybe in the old days, I guess it's about 30 years ago, when a lot of people in AA would say, if you're on an antidepressant, you're not in recovery, which is nonsense. But it took us a long time to actually get over that. So that's kind of where we're at. And I feel a need for this committee to address this at least once a year for now, because I've been threatened with lawsuits several times. Haven't had one yet. That if you don't allow me to be in your program and practice on Suboxone, I'll sue you. And as the research is coming out, I fully expect it down the road to happen. Looking at it nationally, I think what we all heard down in Memphis last week was about half the monitoring programs in the country do allow people to practice while on Suboxone, and the other half are not. Some programs won't even sign a monitoring agreement if you're on Suboxone. Of course, we're also talking methadone, which is rarely used anymore as another medicated-assisted treatment. We are all for the use of naltrexone, Vivitrol especially. And, in fact, I've got where now when I write the summary of the evaluations that we get, I put in there, if there's a narcotic restriction, then a person can be exempted from the narcotic restriction most times if they agree and get documentation they're taking the monthly Vivitrol. Because it's so effective in reducing craving. And also, I think we need to make it protocol that if you're not provided on Suboxone or take them off, we may want to almost insist they go on naltrexone, because a lot of people who get through this very, very difficult taper, a lot of them relapse quickly. So I think taking naltrexone might help. But anyway, let Tom educate us a little bit and share his experiences and his take, because, like I said, he comes from a very strong background, and his thinking's kind of evolved over the years itself. So, Tom, take it away there.
I worked in inpatient treatment facilities for 18 years as a care assistant program coordinator, and those treatment centers were what they call abstinence-based, which I don't even like to use that term anymore. To me, it's like saying this psychiatric facility is abstinence-based, and this one's not. To me, a brain disease is a brain disease. A substance use disorder is a brain disease, just like every other brain disease. So abstinence is almost putting it in a weird spot, whereas it could be in a spot of what you guys do is really difficult, because you have to deal with a large group of people. Everything I do is individual, and I wouldn't want to have to make the kind of decisions that you guys have to make, because I do very individualized treatment. So, Suboxone might be okay for one person, not okay for somebody else. Naltrexone might work for some people, not for somebody else, inpatient, outpatient. But I left that field in 2012, and I started a private practice in Murfreesboro. And there was an opiate epidemic happening at the time, and I got really busy really quick. And I had a patient walk into my office who had seen a doctor who had given him Suboxone, and I was struck by how well he was doing. And his doctor told him that he needed to get counseling as part of a requirement to stay on the Suboxone. I was struck at how well this guy was doing, and I was curious. Didn't know anything about Suboxone at that time. I said, who's your doctor? Got his doctor, never called his doctor right away, talked to his doctor. The doctor, I don't really work with that doctor anymore because what you can find is that some doctors know more about this than others. Some doctors are in this for the right reasons. Some doctors are not in this for the right reasons, just like anything else. And so this particular doctor knew a whole lot about it and taught me a whole lot back then, but, his bedside manner was horrible. And so I just didn't work with him anymore. But I started seeing patients that were on Suboxone, and I started seeing how effective it was. You can look on the internet and these chat rooms and stuff like that, and you can have debates about abstinence philosophy, abstinence-based versus this versus that. But to get down on the front line, which is where I am still, and actually work with patients, I changed my thinking about a lot of this when I was doing that. I was disappointed. Well, let me tell you what I'm doing right now. I have a doctor now that I work with in Manchester. I have a doctor that I work with in Nashville. I have a doctor that comes to my office a couple times a month. I have their cell phone numbers, and if somebody calls my office, I try to help them decide whether or not, because some patients don't want to do medication-assisted treatment. There's some patients that's maybe not the best call,